My name is Priya Patel, and I am a pharmacist by training and now work on the Hemophilia Medical Affairs team at Pfizer. And on behalf of my co-authors at Pfizer, I'm pleased to present this poster entitled Healthcare Resource Use in Men with Hemophilia A and B who have joint disease in the United States. Men with hemophilia experience joint disease as well as pain, which may result in a higher need for medical care. Therefore, the aim of our study was to describe healthcare resource use in men with hemophilia A or hemophilia B who also have joint disease. Administrative healthcare claims data can be important information to help us determine and to help us understand the burden of health conditions and diseases. In this study, a U.S. administrative healthcare claims data was used. Data from January 2010 to April 2020 was used to study men with hemophilia A or B who also have joint disease. The study included 738 men with hemophilia A and 237 men with hemophilia B. They were divided into 4 groups based on birth year. The breakdown of age groups are noted in the lower left-hand corner of the poster. Figure 1 shows the insurance claims for joint surgery, physical therapy, hospital admissions, emergency department visits, other outpatient visits, and pain medication prescriptions in the first year following diagnosis of joint disease. In hemophilia A patients, and shown here in orange, 15% of men had joint surgery. 7% had an insurance claim for physical therapy. 10% had a claim for joint-related hospital admission. 12% had a claim for outpatient emergency department visit. And 32% had a prescription for pain medication. In hemophilia B, shown here in purple, 11% of men had joint surgery, 9% had a claim for physical therapy, 8% had a claim for hospital admission, 13% had a claim for outpatient emergency department visits, and 32% had a prescription for pain medication. Figures 2 and 3 describe joint disease-related healthcare resource use of hemophilia A and B respectively, by age group. Insurance claims for joint surgery, physical therapy, inpatient admissions, outpatient emergency room visits, and pain medications were studied. Comorbidities, as defined as one or more diseases or medical conditions an individual has while having hemophilia and joint disease, were examined in the study. From a list of 20 pre-specified conditions of interest, comorbidities were reported in 32% of men with hemophilia A and 30% of men with hemophilia B. Mild chronic liver disease was the most common amongst hemophilia A and B men. Other comorbidities seen in greater than 5% of men with hemophilia A or B were HIV or AIDS, depression, diabetes, anxiety, and pulmonary heart disease. In conclusion, about a third of individuals were prescribed pain medications, likely suggestive that medical care for hemophilia-related joint disease may require therapies beyond simply over-the-counter medicines. These data pertain to hemophilia patients in general, but research in the future could explore differences due to age or type of hemophilia. And lastly, more research on joint disease and joint surgery among men with and without hemophilia could help identify what progress still needs to be made in the healthcare of persons with hemophilia. On behalf of my authors, I thank you for listening.